Okay, so I'll have you guys get started just because I don't want to keep you guys too late. But I'll start by introducing, welcome everyone to the Transnational VIR Journal Club. This is our 24th session. And today we have Garrett and EJ from Wright State, joined by Dr. Short from Wright State as well. And they're going to be discussing the ECLIPSE and SOLSTICE trials. So if any of you guys are like new members or haven't been to any of the journal clubs but in the past, feel free to email us or follow us on social media and we can get you more involved. So you guys can go ahead now.
Perfect. Well, thank you for the introduction. As you said, this is the 24th installation of the Journal Club. We'll be discussing the SOLSTICE and ECLIPSE trials for cryoablation therapy for metastatic lung tumors. Brief agenda for today's presentation. We'll do some introductions of the presenters, discuss pulmonary metastases, do a general overview of treatment methods. We'll then do a case example from the Dayton VA involving cryoablation therapy, and then we'll discuss the two trials. And then since we're lucky enough to be joined by Dr. Short, at the very end, we'll ask a few questions about his opinions on different ablative methods, and then some more questions about the trial as well. So just to begin, as discussed before, that's EJ on the left, me in the middle, and then Dr. Short on the far right, all associated with the Boonshoff School of Medicine, Wright State out of Dayton, Ohio. I tossed this slide in here to see if the pool EV is working at all. So if anyone can just enter that website in the top and then try to use the pool EV just to see if it's working for this presentation.
So Garrett, I don't think I can see the URL.
You not see the poolev.com/Garrett Fisher at the top?
I don't.
All right. Let me scroll back to the beginning real quick. Can you see the bottom here?
Oh, here I see it. Yeah. I don't know if it was just.
Yeah.
And I can put it in the chat so you can move to the next or to yours.
Perfect. Thank you. And again, that's just to see if the pool EV is working for us. Are y'all seeing the updates? I'm seeing on my screen.
No, I can't see the updates.
Oh. It's working for me earlier.
I see it says for screen share software, share the entire screen to see live content.
Let me see. But if I swap displays, I think it shows.
Oh.
How's that? Can
No
you see
change.
the arrow? No change. You can't see the three. Well, I guess we'll just have to adapt with that. Maybe we'll just do some small, just a quick discussion on the few questions we have then.
Okay.
No worries at all. So I'm gonna let EJ take over from here.
All right. Hi guys. My name is EJ. I'm a MS4 at VSOM, looking to go into IR. So today we're just gonna go briefly about lung cancer, just to kind of set us up for the stage up for our talks about ECLIPSE and the SOLSTICE trial. So a couple metastatic lung cancer facts. It's estimated that 20 to 54% of non-lung cancers would have a pulmonary metastasis. Data from 2010 to 2015 showed that 4% of all cancers presented with synchronous lung metastasis. Median age for people found with lung mets is around 61.8 years, and it's higher in males at 53.5% and 36.5% in females. So pretty much where are these tumors coming from? And primary tumor sites for lung cancer or Mets to the lung mainly come from the colorectal, head and neck, urologic. Sometimes though we can see it from breast and the bladder. Those are just kind of things to look at when you're dealing with metastasis to the lungs. All right, so our first question, in a patient with metastatic lung disease from primary colorectal cancer, what is the approximate 5-year survival rate? And you guys can just throw it into the chat, what you guys think.
This is a lizard?
Oh, okay.
Did you just poop?
This is like barn there.
Stairs.
Dr. Short, I think you're unmuted.
All right. You can go and throw in your answer into the chat, what you think the correct answer is. All right. Well, good. Yeah, you guys got it. 10% is the correct answer. Pretty much overall survival rate for colorectal cancer with Mets to the lung is around 10%. Good. You guys are killing it. Off to a good start. So common clinical presentations. So most of the symptoms that people feel are commonly asymptomatic. And the biggest thing is majority of the time lung cancer with metastatic lung cancer is found is because it's routine surveillance for another cancer, right? So sometimes they have a new onset cough, which is present 50 to 70% of the patients. Hemoptysis, so they're coughing up blood, that's 15 to 30%. Sometimes they get chest pain, and this isn't like your common chest pain that you get with like acute coronary syndrome. It's more kind of just in the thorax area, different parts of the chest. Also get dyspnea, and then hoarseness, depending on where the lesion is. That would be like the Horner or the Pancoast or the, sometimes you get like the flushing and all that. Physical exam and workup for these patients. So on the lung exam, you're going to go ahead and take a listen to these patients. You'll get the monophasic wheezing that's associated with the bronchogenic mass. So if you have a mass that is obstructing a bronchial or any part of the airway, you kind of think of it as decreasing that the cross-sectional area there, which gives you a sound. And in this case, we would hear a wheeze. Crackles found in post-obstructive pneumonia or fluid-filled alveoli. So essentially, the gas exchange distal to the lesion isn't that great. So sometimes you would get buildup of fluid. Therefore, you have kind of stasis of that fluid leading to pneumonia or development of fluids inside the alveoli. You also get decreased breath sounds in pleural effusion. So if the malignancy causes a malignant pleural effusion, sometimes you get no breath sounds at all. And then you can go ahead and also get some atelectasis with that. Signs of malignancy, sometimes they get lymphadenopathy. You can find lymph nodes in the supraclavicular area. Sometimes you get digital clubbing, right? We learn in medical school that those are symptoms of some type of chest pathology. Weight loss, of course, and then the Pancoast tumor and SVC syndrome signs. Again, that's like the flushing. Sometimes you get the Horner syndrome, either unilaterally or bilaterally. Okay, labs and workup. This is kind of the basic stuff that you would get for cancer workup. They would present with anemia, hypercalcemia. We see that with most cancer patients. And then electrolyte disturbances. Some of the new things that are popping up, and it's definitely not on here, is the liquid biopsy, which they're trying to figure out what kind of tumor markers are available. I think there's some on the books for non-small cell lung cancer, but just something to think about in the future and be on the lookout for is liquid biopsy or blood biopsy. Imaging workup. So like we said earlier, majority of these patients these lesions are found because they have another cancer, and it's just workup to confirm that there isn't mets anywhere else. So sometimes they get a contrast CT, and this is for patients with suspected lung cancer. They also will undergo the TNM staging. That's the tumor, primary, the nodes, and then whether they have metastasis or not. The whole body PET or PET CT. This is pretty much to figure out where else has it gone. So they can do brain, and they'll do the whole entire body to figure out if metastasis is found elsewhere. Okay, so imaging, this is kind of the algorithm. We won't go deeply, too deep into the weeds here, but this is from UpToDate. It's pretty much if you have a high suspicion for these lesions, then you would obtain a CT contrast, or CT with contrast, assess the likelihood of metastatic disease, and then you can also perform other imaging like we talked about. And then you select the tissue for biopsy, and that will kind of confirm whether the suspected lesion or not is coming from, is a primary or metastasis. Okay, just imaging continued. We have high sensitivity and that high FP rate. And then that's pretty much just the general idea of it. But then if it's clinically based, you have high NPV or low sensitivity for lymph node metastasis. So there's a table, box 2 here, kind of shows the imaging approaches to identify what we see on the CT or the PET scans that we order. All right, lung biopsy modalities. So in terms of what we can do to figure out exactly if the tumor is primary or metastasis, there's different ways for lung biopsy. One is a percutaneous transthoracic. This is some things that IR can do, fine needle or core biopsy. There's also bronchoscopic that is done by pulmonary. They can do like an EBUS. It's pretty much an ultrasound to then do a biopsy through the scope and get pretty much biopsies from there. Those are more commonly seen in mediastinal lymph nodes that are present within the thorax. Or the other option is through CT surgery to do similar to like a VATS procedure where they do a non-invasive opening of the thorax, go in and find where the lesion is and grab a sample from there. Okay, what is the most common complication with lung core needle biopsy? Go ahead and throw your answer into the chat. A is air embolism, B is pneumothorax, C is hemorrhage, and D is tumor seeding to the biopsy tract, or of the biopsy tract, sorry. There we go. 1 answer in, 2 answers in so far, 3 good. All right. Looks like everyone's on point again. Continuing on the hot streak here. Pneumothorax is the most common complication with a needle biopsy. So you're going into the thorax, causing a hole between outside air and the negative pressure compartments. And therefore, you can have leaks, or sometimes you pop the balloon that the lung is and cause a pneumothorax. So pneumothorax rates is 17 to 26%. This different data is out there. It can be anywhere from up to 50% sometimes, or 33%, sorry, that I've seen in other literature. Hemorrhage, 4 to 27%. If you're getting your needle and you're crossing over a blood vessel and then releasing that, then you can get hemorrhage. Air embolism as well. If you're traversing a blood vessel and then you're exposing air to it, then you can possibly get an air embolism that's 0.06, super rare. And then tumor seeding as well. So for those that don't know, tumor seeding is pretty much getting a piece of tumor, and let's say a little tiny piece of it is like stuck on your needle, and then you pull out your needle, and that little piece that's stuck somewhere on the needle is left on a different part of the lung. Then now that part would be cancerous and could, lead to spread of the cancer. All right, so primary histology. So like we kind of talked about earlier, majority of the time, the primary histology will come from colorectal cancer. And when we looked at the overall survival rate for where it's coming from, you can get a 5-year survival rate up to 68% for colorectal. Renal cell carcinoma is up to 75. Head and neck carcinomas, between 20 and 59, depending on the literature. So with that, keeping that in mind, this is just kind of to set the phrase for what it's like going to be for our ECLIPSE and SOLSTICE trials coming up. Medical surgery, treatment options. So pulmonary metastasectomy pretty much is removing the part of the lung that has the lesions, and that can be done by cardiothoracic surgery. The one is SBRT, which is done by radiation oncology, essentially just high beam energy to the lesion. And then what IR can do, which is percutaneous ablative therapies, that's cryotherapy, microwave ablation, radiofrequency ablation, and laser. And we'll kind of dive into these coming up right here. So what are the indications for percutaneous treatment? So patients that are not candidates for pulmonary metasectomy. So if they have bad PFT values, previous surgeries, other comorbidities that prevent them from getting surgery, high age, I think they have it at above 75 years old is one of the minor criteria, and then refusal for surgery. They just don't want to do surgery at all. For non-surgical candidates, systemic therapy is often the first line. Remember, this is metastatic disease, so med-onc will actually start them on some type of medical therapy. And then subsequent percutaneous treatment methods should be considered if the disease is contained to to one organ system with less than 5 lesions. This is what we call oligometastatic, sorry. IR treatment options, so the methods that we kind of talked about, we have RFA, microwave ablation, and cryotherapy. RFA is alternating electrical current that generates an electric field. The molecules essentially rub together and produce heat. Microwave ablation is electromagnetic waves that are transmitted directly into the tissue, raising the temperature and causes coagulative necrosis. So the difference between those two, I like Dr. Short's analogy to it. It's like one's a toaster oven and one's a microwave. If you put a piece of toast into the toaster oven, you can kind of see it getting heating up there. But if you put a piece of toast into the microwave, you can see that it kind of gets all soggy. So microwave ablation uses a lot of kind of like the water and the moisture is kind of their analogy, what they use for explaining how they make water molecules shake, essentially. For cryotherapy, it's essentially what it is freezing. And freezing thawing process is based on the Joule-Thomson theory. So we can reach negative 185, typically 2 freeze and thaw cycles with passive thaw period. I believe the ECLIPSE is 3 freeze and thaw cycles. All right, next question here. Cryoablation lies on the principle of the Joule-Thomson effect to achieve cytotoxic temperatures. Which of the following correctly describes this effect? A, rapid expansion of a gas that does no work results in rapid cooling. Rapid compression of a gas that does no work results in rapid cooling. And C, who cares? physics is not part of our lives anymore. This might be a harder question. All right. Well, unfortunately, the answer is not B today, for this question at least. It's rapid expansion of a gas that does no work and results in rapid cooling. Pretty much what that means is when you go from high to low pressures, then you get rapid cooling. We don't have to dive into the physics. If you want, you can Google the Joule-Thomson effect to kind of explain or have a better understanding of how that works. But keep that principle in mind for what we do for cryo here. Okay, so we talked about the methods that ablative methods that are available. RFA is the most studied methods, and it's been around since like the early 2000s, but it's kind of lost its heat a little bit. It requires consideration for heat dissipations and effects of neighboring blood vessels and airways. The other thing is for microwave ablation, these are shorter ablation times with higher intratumor temperatures, fewer heat dissipation effects compared to the RFA. And then the biggest thing right now is a little bit more new, and we have fewer long-term data or follow-up data, which hopefully, which Dr. Short is actually currently working on. As for cryo, cryo's been around for a while. You can evaluate ablation site in real time, which is shown in the ECLIPSE trial that we're going to talk about. And you have the presumed analgesic effects. And then further studies are still needed just to see what exactly is the best way to do cryo. All right, we have a case example. This is directly from Dr. Short, one of his patients. We had a 57-year-old male with a past medical history of colorectal cancer. He underwent CT of the thorax, and he was found to have a 14.2 millimeter nodule in the posterior left lower lobe. Image there. Please forgive the classic orientation that we're used to. The PET lesion was showed positive uptake, and the diagnosis of metastasis from colorectal cancer was proven via biopsy. Patient did refuse surgery, and then they decided to undergo cryoablation after Dr. Short presented them with all the other options that we talked about. So what happened to this patient? They did cryoablation of the pulmonary tumor. This was done under moderate sedation under the ECLIPSE protocol. This is these two 17-gauge iSphere probes. For this lesion, they put one above and one below, kind of like the lesion, to make sure that they got a full circumference of it. They were discharged 4 hours post-procedure without complications, and the most recent follow-up we have on them is 16 months without a recurrence. So here we can see in the pictures, we have that left lower lobe. Dr. Short did the cryotherapy needles, kind of a posterior approach, got his needles directly into the tumor, and did the ECLIPSE protocol, which is the 3 freeze and thaw cycles. This imaging here at the bottom is the coronal image. If you're looking directly like at the lungs, there's the left side there. You can kind of see that the tissue around it looks different from how it did previously in the image right before the slide here. Okay, and we're going to jump into the SOLSTICE and ECLIPSE trials now.
Sounds good. Well, thank you, EJ, for such a great description of the different ablative modalities, and then really cool case example from the Dayton VA using cryoablation. So as mentioned at the beginning of this presentation, we'll be covering the SOLSTICE and ECLIPSE trials, which are really just sister trials evaluating efficacy of cryoablation for the treatment of pulmonary metastatic disease to the lung. Some of the authors do overlap, and they definitely have the same goal in mind. So moving right along, starting with the SOLSTICE trial objective and design. So their research objective was to assess the safety and local recurrence-free survival of cryoablation therapy for the treatment of pulmonary metastatic disease that's less than 3.5 centimeters. A bit about the study design. It occurred across 10 centers, multinational, I guess multinational is the right word, 8 in the US, 2 in Europe. Period of patient enrollment was between April 2014 and March 2016. Total of, after inclusion and exclusion criteria, 128 patients with 224 total tumors. Now comparing that with the ECLIPSE trial, the ECLIPSE trial stated objective is to evaluate the feasibility and efficacy of cryoablation for local tumor control in patients with pulmonary metastatic disease in 5 years of follow-up. They also have a 1-year interim data that they published as well. This study design was a little bit smaller. They were included 4 centers, 3 in the US, 1 in Europe. Period of patient enrollment was a little bit before the SOLSTICE trial between January 2012 and March 2013. This study had about a third of the patients the SOLSTICE trial did, at around 40 patients with 60 total tumors. All right, so inclusion and exclusion criteria for the SOLSTICE trial. Inclusion had to be over 18 years old, confirmed pulmonary metastatic disease. They really wanted a histologically proven primary tumor, so they could see where the cancer originated from. Again, maximum tumor size of 3.5 centimeters. They want a KPS scale greater than 60, which is sort of a quality of life measurement. Platelet count greater than 50,000, and then life expectancy greater than 3 months. Some exclusion criteria include primary lung cancer, uncontrollable disease outside of the lung, inability to lie flat, uncontrolled coagulopathy, neutrophil count less than 1,000, any preclusion from informed consent, and then any participation in other clinical trials that would affect their primary endpoint, which we'll discuss in a little bit. Real briefly here, inclusion exclusion criteria for the ECLIPSE trial, relatively similar as the SOLSTICE, but they just had less of both inclusion and exclusion. Only real differences is they include the ECOG performance. One of the endpoints was quality of life in the ECLIPSE trial, which we'll discuss further. They did also discuss a maximum of 3 unilateral or 5 bilateral mets, and then no previous therapy. Some exclusion criteria, roughly same as SOLSTICE trial, so I'm not going to get too much into that. All right, so here are the endpoints for the SOLSTICE and ECLIPSE trial. SOLSTICE, they said the primary endpoint is efficacy of cryoablation for each index tumor on local recurrence-free response at 12 months. And then they also secondary endpoint, excuse me, of local tumor efficacy after a single or repeat cryoablation at 12 months. ECLIPSE trial, primary was local tumor control per tumor and per patient. And then as I was mentioning a little bit earlier, that secondary endpoint is they wanted greater details, including cancer-specific survival, overall survival, and then a quality of life measurement, where they use KPS, ECOG, and then the short form 12 health survey. So here were some of the parameters that were set forth in the SOLSTICE trial, along with some diagrams on the right that they included. As mentioned before, greatly described by EJ, was the Joule-Thomson effect, principle of physics principle that cryoablation follows. They highlight that cell death occurs around -20 degrees Celsius. And then, so their average freeze duration was 20.6 minutes plus or minus 4.3. Again, highlighting that freeze thaw cycles allow for visualization of the ablative zone. Really important in their guidelines, and I believe in the ECLIPSE guideline as well, is they wanted a 5 millimeter ablation zone around the tumor, just to be certain that they're fully ablating the tumor, trying to reduce the recurrence and give the best treatment as possible. And then the figure right is a 1.2 centimeter rectal carcinoma met to the right lung. A showing at 1 month, D at 12 months, and then C at 12 months. Actually might be 24 months follow-up. I'll have to clarify that though. As you can see, looks like a great response. And then this was ECLIPSE parameters for cryoablation, similar to what Dr. Short used the VA for cryoablation. But within their study, the average number of tumors per patient was about 1.8 plus or minus 1. Average procedure time, 101 minutes. Free duration per tumor was 21.2 plus or minus 4.6, which is very similar to that, the SOLSTICE trial, average freeze duration. And then number of freeze thaw cycles, like EJ mentioned, try to at least have 3 is the goal, according to their protocol, but there's some variation there. All right, I think an important consideration when before looking at the results of each trial is evaluating what were the primary histologies of the cancers, because a lot of the overall survival can be predicated on what the original cancer was, whether it be rectal or renal cell carcinoma, et cetera. As you can see here, the SOLSTICE trial had a lot more variability here on the left side of stated primary histologies, most common being colorectal at 49%. And then y'all can really read through the rest of those. I don't want to get too repetitive here. And then the ECLIPSE trial, again, had mostly colorectal at 17, and then renal cell and sarcoma, but then they didn't really define the other ones. So it did seem like SOLSTICE was more thorough, and number one, increasing their N value, more patients, and then number two, having a variety of primary histologies in their trial. So now let's move forth, discuss the results a little bit. So again, primary and secondary endpoint for SOLSTICE trial, primary being 12 months recurrence-free with 1 ablative treatment, secondary being a secondary ablative cryoablation being required. So 85% recurrence-free at 12 months if there's just 1 ablative treatment, 91% if there's a second ablative treatment. At 24 months, it was 77%, 84% respectively. Overall survival rates at 1 year for the SOLSTICE trial was 97.6%, 2 years at 86.6%. And just to highlight any sort of adverse effects that occurred in the trial, they reported grade 3 or greater adverse effects at 6.2%. So it seems like a very well tolerated procedure. Moving along to the ECLIPSE trial results. Again, they had 1 year published a little bit, I think a little bit back, just their interim analysis. 1 year survival at 94.2%, 3 years at 87.9%. Excuse me, this is just local tumor control rate, so recurrence-free. 1 year at 94.2%, 3 years at 87.9%, and then 5 years at 79.2%. Overall survival rate at 5-year follow-up, they reported 46.7%. As I did note, the quality of life was an endpoint in the trial. However, they did discuss that quality of life improvements were not considered statistically or clinically significant. They did cite a major factor was the fact that many patients didn't fill out the forms or report the various parameters, KPS, ECOG, or short form factor 12, which may have been a factor in why there's not statistically significant data there. And then grade 3 or greater events in this trial was 5%. So again, a well-tolerated procedure. So just conclusions from each trial. Again, each trial aimed to show that cryoablation is effective and well-tolerated for the treatment of metastatic disease to the lung. The SOLSTICE trial is currently the largest prospective multi-center trial utilizing image-guided percutaneous cryoablation for metastatic lung disease. Again, well-tolerated with encouraging efficacy. ECLIPSE highlighted at the end of their report that it is, again, an effective means for local tumor control of metastatic lung disease. Excuse me. And that additionally, further studies are needed to compare local therapies with surgical resection. As EJ highlighted earlier, the main treatment modalities are surgical resection, SBRT, and then the various ablative mechanisms. And there's really no literature now comparing the efficacy, how how well each treatment is tolerated, which is definitely a point for future research. Some brief limitations from each trial. So the SOLSTICE, they reported mixed primary histologies that will require further analysis for overall cancer-specific survivals. Additionally, scar formation at ablation site is included in response to treatment rather than disappearance of treated tumor. ECLIPSE, as we discussed, it's a pretty small patient cohort at 40 patients, and it was heterogeneous in disease presentation and course. And then they also highlighted lack of reported details regarding systemic therapy post cryoablation. So they didn't really know what sort of systemic therapy their patients were on. So that's the end of covering our ECLIPSE trial. Since we're so lucky to be joined by Dr. Short, if anyone has any questions they'd like to ask, we can toss those in the chat or you can ask them. Otherwise, I have a few questions we can ask as well. Dr. Short, are you here?
I am. Can you hear me?
Yeah, absolutely.
Great.
So I guess I'll start it off, Dr. Short. Can you highlight your experience with the cryoablation versus radiofrequency ablation versus microwave ablation?
Sure. I will say as a, somewhat mid-career attending now, I have very little experience with radiofrequency ablation in the lung. But that is sort of the giant whose shoulders we stand upon now, that all of our ablative data, started in the liver and then went quickly to the lung and the kidney, started with radiofrequency ablation because that was the first technology available to us. Radiofrequency is not particularly well suited for the lung. There are some physics limitations there in terms of it being an impedance-based technology. Well, lung is some of the highest impedance tissue in the body, second only to bone. So meaning that you're not going to get good propagation of current, and so you won't get good heating necessarily in the lung. The lung is sort of a natural insulator. So I don't have much experience with radiofrequency in the lung because I had the good fortune to be in my training. We had microwave ablation had just come along and we started using it with liver. I did my first microwave ablation in the lung in 2016. I tend to be a more heavy user when it comes to image-guided thermal ablation in the lung. I tend to use microwave more, and I think that's just user preference. I don't think that one is necessarily superior to the other when we're talking about microwave ablation versus cryoablation, or even radiofrequency ablation in the right hand. In the right hands, we have some users, some of our European colleagues that have done thousands of radiofrequency ablations. I think it comes down to being comfortable with the tool in your hand and knowing what that tool is capable of. And so that means understanding the physics of how that particular device works. And when I say particular device, I mean not just the modality, but that particular vendor, right? Not all cryoablation is cryoablation. The needles work a little bit differently between the different vendors. Or even within the same vendors. You have ice rods versus ice spheres. And, really, I think of myself as an ablationist, as, I'm a sculptor in some ways. Like I'm trying to cut or freeze holes in people's bodies in the right size to fit the right circumstance. So with that in mind, I have used microwave more heavily historically than I have used cryoablation. When I tend to use cryoablation is when I can't meet what I think are the technical necessary parameters for a microwave ablation. I think for a microwave ablation, you need to cross 3 centimeters of healthy lung with your ablation probe. And if you can't cross 3 centimeters of healthy lung to get to that ablation or to your lesion, what you're risking is burning a hole in the lung that communicates with the pleura. And if that hole communicates with the pleural surface and a bronchus, we call that a bronchopleural fistula. And so the early data with microwave was sort of replete with complications related to not considering that technical factor or using too much power in in the ablation. So when I do microwave, I tend to do it at a lower power for maybe a little bit longer time. So I'm usually in the 50, 65 watt range for say 5 minutes or so for microwave. For a cryoablation, the nice thing about cryoablation is it's a little gentler on the connective tissues, of which largely the pleura is made up of. So if I have, usually it's a pleural-based lesion or a larger lesion, right? I like to keep my microwave ablations to 3 centimeters or less, generally speaking. Every now and then, I may try to take on a larger lesion, particularly a chest wall lesion. Chest wall lesions are very, very difficult for surgeons, right? Because you're resecting part of the chest wall, and that will break down. And so it's a very difficult surgery for the thoracic surgeon, but it's actually somewhat straightforward for us if somebody has pain related to metastases to get local control by using cryoablation. And cryoablation preserves the collagenous matrix. So that said, I'm probably about an 80% microwave, 20% cryoablation. Now, that's just me. There are practices, for example, a lot of the authors on the ECLIPSE and SOLSTICE trial, as you pointed out, they overlap. And so there aren't a whole lot of vastly experienced lung ablationists in the world right now, but it's growing and it's taking off. And I think why there is not is because we need more data, we need more education, and that's something that the SIO and the SIR is working on. Kind of a long-winded response to your question there, Garrett, which do I use and what's my experience? But I use both, and I use them based on the lesion characteristics and location. Characteristics being size, geometry, proximity to a vessel, proximity to the pleura. And there are folks that are the opposite, that are mostly ice. You have your ice folks and your fire folks, and which you choose, I think, just depends on your training and your experience.
Sweet. That was a very thorough response. I appreciate that. Another question, if you don't mind. I know at the end of the ECLIPSE trial, they highlighted the need for more research comparing maybe surgical resection versus SBRT versus ablative mechanisms. Do you see that ever being feasible, or is that something that is just more hopeful than actual possible to compare those means?
Hopeful. I continue to keep my fingers crossed for that. That is the dream. What we need is a randomized controlled trial comparing image-guided thermal ablation to SBRT and or surgery. It's been attempted. Right? There have been some trials that have come close. The Rapture trial, which was done in 2008, was a multi-center trial by Lencioni, was the primary author on it. And they looked at radiofrequency ablation for non-surgical candidates in a prospective fashion. But it wasn't truly randomized. It wasn't people who are surgical candidates being randomized to a non-surgical therapy. This issue comes up anytime in interventional oncology we try to do that kind of trial. And it's not just for interventional radiology. It happens for radiation oncology as well. So radiation oncology has a little bit more robust data for SBRT than we have for image-guided thermal ablation. But there has yet to be a randomized controlled trial comparing SBRT to surgery for pulmonary malignancies. 2 trials were attempted and both closed due to lack of recruitment. These were the STAR and the ROSAL trials. There's a 3rd trial that looks like it has a chance, and it's called the VALOR trial. The VALOR trial is being done within the VA, and there are certain opportunities afforded within the VA to do a large multi-center trial like that that's difficult to pull off elsewhere. Some of it relates to funding, some of it relates to patient selection. But what it comes down to is oftentimes when you try to do a procedure-based trial, patients are told that, well, we're going to randomize you to one procedure or another. and they drop out once they're randomized to the procedure that they didn't want. And so there's some ways around that. And I think if we can incorporate that in future trials, there's a chance. But you also have you got to bring specialties together to conduct a trial where the other two specialties have something to lose. If they see it that way, that's unfortunate. But I think that somewhat is, if you think about it, do you want to be the surgeon participating in a trial for a procedure that could supplant your surgery? This could replace surgery. These trials have been very difficult to perform in the liver, even more difficult to perform in the lung. And same with our radiation oncology colleagues. If you look at the comments that you saw in the Journal of Thoracic Oncology after the SOLSTICE trial, the conclusion there is that it's a safe and effective therapy for pulmonary metastases. And I think the data supports that and the study as presented. But there was a letter to the editor from a group of radiation oncologists, and the title of it was, "Is it really safe and effective?" That they'll question the trial even when presented with the data, because it threatens to encroach on turf. And that's something that we just deal with in medicine as a whole, I think, in our fee-for-service model, that makes these trials difficult to perform, both in terms of recruiting providers willing to participate and then recruiting patients. Because think about, if you are told that there is a less invasive option, you may say, well, I'm willing to participate in the trial provided I get that less invasive option. And the opposite is true too. I occasionally have a patient that says, I just want this thing cut out of me. So I'm not aware of any randomized controlled prospective trials looking at SBRT versus ablation, or SBRT or surgery versus ablation. There are a number of studies out there that are retrospective. We're working on one at our institution. There are lots of meta-analyses, right? And this is how you build your quality of data when it comes to trying to advance a new therapy. You start out with case reports. You start out with trials like ECLIPSE and SOLSTICE. ECLIPSE was a smaller patient cohort of 40 patients, but it was at least prospective, and it was multi-center, right? And then SOLSTICE was deliberately way more patients, a larger cohort, right? And the goal is to follow them out longer as well. So now we have 5-year follow-up in 40 patients. We need 5-year prospective follow-up in the 130-ish patients, right? And then we have these meta-analyses that are coming out now to support the therapy, to where it is now at least supported somewhat in the guidelines. And so it's baby steps in terms of getting there and building data. But back to your original question, that's the dream, is the randomized controlled trial. It just hasn't happened because the other 2 trials that have been designed on the SBRT, STAR and ROSAL, were closed due to lack of enrollment. And I think the fear is the same. And then who pays for and who coordinates such a large, complex study, bringing together thoracic surgery, interventional radiology, and radiation oncology to do the study? It's the dream. Somebody needs to do it. And I think we have seen some interest from some industry partners in the ablation space. So it may happen. There may be another swing at it. We're looking at it within the VA system. If it were to be pulled off, I think that's one of the places that it could be. But the problem is we don't have a lot of operators within the VHA system that are comfortable doing lung ablation. So I could talk for a full hour about that. I'm going to cut myself off. So sorry about that. So.
No, that was great. I appreciate the thorough descriptions, and it definitely seems like there's a lot of complexities as to why that might not be feasible anytime soon.
Yep.
All right. Well, if there's no other questions, I don't see in the chat right now. I think EJ. I'll go to EJ.
Sorry, I do have a question for Dr. Short, just briefly. So how has the ECLIPSE trial or the SOLSTICE trial affected your practice? I know we see it adopted into your protocol for your patients with cryoablations, but when would you ever stray away from this protocol, or what did you do prior to knowing about the ECLIPSE protocol?
Can you still hear me?
Yeah.
All right, good. So before the ECLIPSE protocol, I think most of us were using what we call a double freeze. And, you know, the way cryoablation works, again, goes back to understanding the physics. It's not enough to just freeze something and thaw it, right? You could be, because that's cryopreservation, right? If we freeze tissue, that's how we, you know, freeze sperm or eggs or Walt Disney, right? We put them on ice, and as long as we thaw them out slow enough, we hope that they will be alive and ready when we need them. So the opposite is true for cryoablation. You want to freeze and thaw rapidly so that you create cracks within the cells at a molecular level, right? And that leads to some osmotic effects, and it leads to cracks in the organelles, and leads to apoptosis and cell death. So before the triple freeze protocol, that is the ECLIPSE protocol, we would do, say, 10 minutes freeze, 5 minutes thaw, 10 minutes freeze, 5 minutes thaw. So the ECLIPSE protocol, I think the ingenuity there was, we know in lung that there's very little fluid occupying the space. So how can we change that? How can we change the game? Well, let's do a quick freeze and a quick thaw so that we deliberately induce hemorrhage early into the surrounding space around the lesion. And it's that hemorrhage then that can drive the ablation through the freezing and thawing and creating of ice. You need some sort of fluid there. So I think that early freeze thaw and driving fluid into the, you know, into the interstitial space around the tissues gave us better results. The results that we see in SOLSTICE and ECLIPSE are better than the other cryoablation trials before them, I think, for two reasons. One, very experienced users, and they standardized the protocol. And then they moved to that triple freeze. Now, when I modify that protocol, if I modify anything, it's the length of the second and third freeze. It's not, so I'll still do a short 3-minute freeze, 3-minute thaw. I may sometimes go to just 7 minutes or just 5 minutes for something smaller. There are some of my colleagues out there they will do just a double freeze where they say, I do a 15-minute freeze on that second freeze. And then I feel like that's enough. I think that's fine if you're an experienced user and you know what you're doing, but for these kinds of trials, and as you're starting out, I would make sure that you are being regimented and systematic in your approach and not playing with too many variables. Learn what a triple freeze, 3-minute, 10-minute, 5-minute, 10-minute, 5-minute will produce for you before you start trying to change the parameters too much.
Thank you.
All right. Well, yeah, thanks everyone. Thanks EJ and Dr. Short for joining me in this presentation. And I think that does it on our end.
All right. Nice job, everybody.
Thank you guys so much. That was really informative.